Hello, podcast family. Thanks for being here with me this week. I just got back from the Richmond International Film Festival where the business of birth control was being screened. And in case you don't know, it's a documentary that was produced by Ricky Lake and Abby Epstein, the same ladies who brought us The Business of Being Born back in 2008. So this new film delves into the problems with hormonal birth control, and it's 100% a must-watch for all of us. You can find it at thebusinessof.life or find them on Instagram at thebusinessofbirthcontrol. Highly recommend. So my guest on this episode is Dr. Michael Green, a board-certified OBGYN and the Chief Medical Officer of Winona, a telehealth service that offers hormone replacement therapy to women in perimenopause and menopause. Our conversation centered around hysterectomy, which Dr. Green specializes in as an OBGYN. We explored the various types of hysterectomy, surgical approaches, including laparoscopic, abdominal, and vaginal hysterectomies, and considerations for women considering this procedure. Dr. Green sheds light on the medical conditions and circumstances that may lead to a hysterectomy recommendation, as well as the age and factors influencing the timing of this surgery. We also address concerns about younger women being offered hysterectomies for various conditions and the impact of a partial hysterectomy on ovarian function. Dr. Green also shares essential post-operative care and recovery expectations, alongside the importance of hormone replacement therapy to support overall health and hormone balance in the long term. As an aside, the fact that I just shared that I'm in a movie about the inherent problems with hormonal birth control means that I don't personally agree with all of Dr. Green's approaches for heavy bleeding, including using hormonal birth control as a solution. However, that is obviously his choice as a doctor, and I totally respect that. And at the same time, I want women to be looking deeper for the underlying causes of their period-related symptoms. But if you've been here a while, you already know that. Enjoy the show. Hi, Mike. Thank you so much for being here with me on the podcast today.
That was my pleasure. I'm looking forward to it. Thanks for having me.
Yes, absolutely. So we're going to be talking about hysterectomy, perimenopause, menopause, hormone replacement therapy, like a whole mishmash of things. But I wanted to center the conversation on hysterectomy because, well, you know, it is the second most common surgery done on women in the US after C-sections. And I've actually never dedicated an entire episode to this topic. And so I thought maybe we could start with the various medical conditions or conditions that might lead to the recommendation of a hysterectomy, maybe some common reasons why this surgery is performed.
Sure. So let's start with the scary bad stuff. Cancer is obviously the one that nobody wants. And most of the female cancers, apart from vaginal cancers, require hysterectomy. So cervical cancer, uterine cancer, ovarian cancer, all require hysterectomies. And the hysterectomies done for cancer surgeries are really much bigger and more involved than hysterectomies for what we call benign disease or non-cancerous reasons, because they involve sampling lymph nodes and taking out extra tissue just to make sure cancer hasn't spread. It's kind of a separate category of its own, and those it's really a different surgery. And even regular gynecologists don't perform those surgeries. Those are performed by like these super specialists, these what's called GYN oncologists, who typically tend to be like the best surgeons in the whole hospital. These folks are amazing. So that's sort of the scary one, which nobody wants to have a hysterectomy for. No one wants to have a hysterectomy anyway, but you certainly don't want to have it for that. So that's sort of the big category, I think, kind of to put aside, because it's not the normal reason. So most hysterectomies are done usually for bleeding problems that are difficult to control. So fibroids are probably the most common reason. Fibroids are benign growths of the uterus. It's actually normal uterine tissue that just grows funny. They grow in like these little balls. And so they're not even necessarily disorganized, they're just organized wrong. They're like little hard balls inside the uterus. And that can affect a lot of things. It can cause pain. It can cause bleeding is probably the biggest thing. And sometimes these things grow like crazy and you can look like you're 20 weeks pregnant from this giant uterus. So fibroids are very common and can be a big problem. The interesting thing about fibroids is if you just took women off the street and did ultrasounds, at least 25% of them will have fibroids. Most of them would never know about it. So most of the time fibroids actually don't cause problems. So if you're having an ultrasound for some other reason and somebody tells you you have a couple little fibroids, don't panic. It's probably nothing. So most of the time, fibroids don't cause problems. But for some unfortunate people, they really do. And sometimes they just grow like crazy. So that's probably the most common reason to do a hysterectomy, would be for fibroids. Now, fibroids, all this stuff can be treated other ways with various degrees of success. So birth control pills can often help control bleeding. Some of the IUDs, particularly the progesterone IUDs like Mirena, do a really nice job for a lot of women of controlling bleeding. So a lot of times we're able to do other things besides jumping to a hysterectomy to get bleeding under control. There's also a procedure called an endometrial ablation, which is a surgery, but it's a really minor surgery where basically under anesthesia, we go in and burn the inside of the uterus to keep it from bleeding. And that's really, over my career, changed. I mean, it didn't exist when I started, and then it was like really bad, and now it's gotten like really good. And so because of that, hysterectomy for bleeding has become less and less common, fortunately. Between the IUDs and the ablations, we're usually able to control bleeding without jumping to major surgery, which is a good thing. But still, for some women, we just can't seem to get control of the bleeding. And so hysterectomy is done for that. Okay. There's something called adenomyosis, which is this funny thing where the glands that are supposed to be sort of on the inside of the uterus kind of grow into the body of the uterus itself. That can also cause bleeding, but it can also cause a lot of pain, particularly during the periods. And so that's another common reason for doing hysterectomies. Interestingly, the contraceptive implant Nexplanon, that's a little implant that goes in the arm, is actually pretty good at helping with pain with periods. So, and it's not really that well utilized for it. I don't think that many people know about it. The IUDs work well for bleeding. The contraceptive implant actually works well for menstrual pain. So that's another way that sometimes you can kind of avoid surgery. But adenomyosis would be another common reason for surgery. The problem with adenomyosis, which is pretty frustrating, is we can have a pretty good idea about it before surgery, but you don't really know 100% until after surgery and somebody actually, the pathologist, looks at the uterus under the microscope and says, oh, yep, there it is. That's what caused the pain. So that can sometimes be a little bit frustrating. Yeah. Precancerous conditions sometimes lead us to hysterectomy, and those, because they're not actually cancer, are done like a normal hysterectomy rather than the cancer hysterectomy. So there's something called hyperplasia, which is an overgrowth of the inside of the uterus, and particularly if there's what's called atypia, where there's some, it's not just overgrowth, but some funky looking cells. That's a sign that, hey, uterine cancer is around the corner, and so usually it's often best to just take the uterus out instead of risking it. Some of the abnormal pap smears, when they're kind of, mostly those can be treated with pretty simple procedures, but occasionally if they're pretty advanced, doing a hysterectomy might be the best treatment. So those are all sort of different reasons for hysterectomies. Prolapse, that is where the parts are falling out, particularly the cervix and the uterus, is often treated with hysterectomy as well. So the hysterectomy has some weight, and if the ligaments and the tissues are really lax, usually from having lots of kids, taking that uterus out can help keep things from falling out. And so that is another time where hysterectomy is done. So it's not completely comprehensive, but I think that's a pretty good list of why we sometimes need to do hysterectomies.
No, that's super helpful. One of the other ones I often hear in my work is endometriosis, which is unfortunate because obviously endometriosis is not actually really a problem with the uterus per se. So do you see that, or have you seen a lot of that in your time as well?
Yes, endometriosis is another one. And that one's really challenging as well. For lots of reasons, but particularly it's interesting that the amount of disease doesn't necessarily correlate to the symptoms. Yeah. So you'll have some people that are just miserable and they have just a teeny amount of endometriosis, and you have some people, like I've done tubules on people, and you go in there, it's like, gosh, there's endometriosis everywhere, and the patient feels great. It's like, okay, that's hallelujah, you know? Yeah. So it's an interesting disease that way. And sometimes there's lots of treatments for it, but sometimes people are just so miserable that hysterectomy is the way to go to get people their life back, basically.
Right. Yeah. Or, I mean, at least to relieve the symptoms associated, right? Like the heavy bleeding and the pain.
Heavy bleeding, pain.
Yeah.
Usually there's a lot of pain, and it can be debilitating.
Yeah.
And really interrupts their quality of life. So I think that's if that's sort of the option that's left, it's a pretty reasonable way to go.
Right. Yes. So, speaking of, you mentioned all these different things. I know that there are also different hysterectomies or different types of hysterectomies. Like we have the total and then the partial and the radical. Can you just elaborate on these differences just so that everyone listening really understands the differences between these procedures?
You bet. And actually, this is kind of a frustration for all OBGYNs because there's a disconnect between the sort of normal everyday lingo and the medical terminology. And so a patient says one thing and we hear something else, and then we both think different things happened. So medically speaking, you can have a total hysterectomy, and that means removing both the uterus and the cervix, or a subtotal, or sometimes we say partial, but a subtotal hysterectomy or a supracervical hysterectomy is another way to say it, where the cervix is left in. Whether the ovaries are taken out or not is really considered a sort of a complete separate surgery or concept as far as the naming goes. So when we say that somebody had a total hysterectomy, we don't mean we took the ovaries out. We mean that we took the uterus and the cervix out. But for a lot of women, when they say they had a total or a complete hysterectomy, what they really mean is that they had the uterus, the cervix, and the ovaries removed. So it's important to communicate correctly. I think most of us are pretty clued in to like ask the follow-up question, but it's pretty easy to get confused that way because the lady says one thing and we hear something else, and then we misunderstand each other. So it's pretty important to be real specific. So the removal of the ovaries is called an oophorectomy, and if you take the tubes out, that's a salpingo oophorectomy. So there's these big long terms. So we just say RSO, like right salpingo oophorectomy, or BSO, bilateral. That would be both because it's a lot easier to say. So that's sort of the medical terminology. Again, it's just difference in sort of the nomenclature or the language that we speak. So sometimes it's better to just say in like plain English, oh, they took my uterus and my cervix out, or they left my cervix in, or they took my ovaries, or they just took one ovary. Just that way, everybody understands what you mean.
Right.
And then, did you want me to talk about the different ways to do a hysterectomy? I can't remember.
Yeah,
that was part
actually,
of
yeah, that was actually going to be my next question. Yeah, exactly. So like the different types, I know that there's like I think it's laparoscopic, and then there's abdominal. I think there's multiple different options, right?
Correct.
Yeah.
So, when way back in the old days when I was trained, basically there was vaginal hysterectomy and abdominal hysterectomy. Those were pretty much our choices. So I finished residency in '99. I actually did a family practice residency first and then did an OB residency. So I'm like overtrained. So I can remember back in family practice residency assisting some surgeons on some of the very first laparoscopic gallbladder surgeries, and just the frustration and cussing and like that went on because the equipment was so bad and nobody really knew what they were doing. But this was certainly the way to go. Now almost nobody has anything but a laparoscopic gallbladder surgery. And the same thing with hysterectomies. We really weren't doing laparoscopic hysterectomies when I was in residency. That equipment just wasn't advanced enough to do that properly. And so that's something that's now sort of taken over the field. So let's start with the sort of basic stuff. So vaginal hysterectomy. So to me, that's like one of the coolest things I can do is to remove a uterus out of a lady's vagina, and she does well. It's like, so, I don't know. I'll tell you a funny story. So when I have 3 boys, and so I was in Cub Scouts forever as each one went through, and I'm like really bad at arts and crafts, which is not where my skill is. And so the kids used to laugh.
You've got other skills, Mike.
I've got other skills. Yes. So the kids used to laugh at us that it was Dad Scouts because invariably we'd start some project with the kids. They'd get bored. They'd run off in the back and play, and us dads would finish the project. And mine would always come out terrible. And so the other dads would laugh at me, and then I'd say, "Yeah, but I can take the uterus out of a lady's vagina." That was always
Oh
a
my God.
punchline at the end of concept. And
Oh,
then
man.
they go, "Oh."
Yeah.
Now, most of their wives are my patients, so it was kind of
Nobody can top that. Seriously.
So vaginal hysterectomy is actually when it's done, when you have the right patient that's done right, it's super slick. It's a half-hour, 40-minute procedure. You know, we used to say 35 minutes, 35 cc's of blood loss. It's almost a bloodless surgery. It's really nice. There's a pretty high learning curve, but once you get good at them, they're a really nice way to go. It's kind of a dying art because the robotics and the laparoscopic stuff is a lot more sexy, you know, and that's what people want. But the vaginal hysterectomy, if it's doable and you have a skilled surgeon, it's a great way to go. So that's sort of number one. Then there's the abdominal hysterectomy, and it's done basically through the same kind of scar we use as a C-section, and we just take everything out through the abdomen.
Okay.
And then the laparoscopic stuff has really gotten super advanced. So at first, when we were doing laparoscopic hysterectomies, we started off with what we called laparoscopic assisted hysterectomies, where we do some of the stuff laparoscopically, and then we jump down vaginally and we do the rest vaginally. And that allowed us to do hysterectomies vaginally that we weren't otherwise able to do. So it saved a lot of women abdominal hysterectomy, but they got kind of two procedures. Once people got good enough in the laparoscopic equipment and got better, we were able to do the whole thing through the laparoscope, which is really nice. There was an piece of equipment called a morcellator, which basically you could just, was this thing that would take the uterus out in little pieces. And yeah, it sounds horrible, but it actually worked great. But there were some rare problems with it, and it eventually went off the market. So I don't think that's being done anymore. But a laparoscopic hysterectomy is really nice. It's done with usually 3 holes, maybe more, little teeny holes, yay big.
I just had an appendectomy last year, so I know, I totally know what you're talking about.
Right.
Yeah, those little
holes. So cosmetically, it's nice. The recovery is much less than an abdominal hysterectomy. We're able to, you know, get it all done through those little holes.
Right. Is an abdominal, real quick, is the abdominal one kind of like a C-section scar?
Yes.
Or, yeah, okay, right. Okay,
yeah.
surgery. Yes.
It's almost exactly the same as a C. It's a little bit bigger, but it's in the same spot.
Right.
And it looks very similar to a C-section scar.
Okay.
And now they have this robotic hysterectomy. And there's a lot of controversy about this. So the data really shows that the robotic hysterectomy takes longer, doesn't really save anything as far as complication over a laparoscopic hysterectomy. On the other hand, depending on what needs to be done, so for instance, for cancer surgeries, the robotic hysterectomy is really helpful. Or if certain bladder procedures need to be done at the same time, the robot can really help. So part of what's done, honestly, with the robotic hysterectomies, and I don't do the robotic hysterectomies, but you have to do a certain amount of them to keep your skills up. And so if you're going to be doing the more advanced robotic techniques, you need enough cases to be good at it. And so some people will include, instead of doing a laparoscopic hysterectomy, to do a robotic hysterectomy, basically to keep their robotic skills up, which is a reasonable thing because you want people to have the skills to do the higher level. And so, you know, there is some controversy on the robotic hysterectomies. Some people think they should never be done. Other people think there's a place for them, but that's another way. It's basically a really advanced form of laparoscopic surgery.
Okay. And so would there be a reason to do one over the other? Like, are there more complicated situations for some women versus others?
So there are. So let's start with vaginal. The vaginal hysterectomy, in order to be able to pull it off, so to speak, you've got to be able to reach the blood vessels and the ligaments from the vagina, and the uterus has to be able to fit. Well, you can actually piece it out, but you basically have to be able to fit it through. Also, you can't guarantee that you can get the ovaries out vaginally. Sometimes you can, sometimes you can't. So if the surgery needs to involve removing the ovaries, the vaginal hysterectomy is not really the way to go because you can't sort of guarantee. And that's where we used to do the laparoscopic assisted vaginal hysterectomies. And some people still do those. I think most people now would just do a pure laparoscopic case, where you go in laparoscopically and take the ovaries out, and then you do the rest of the case vaginally. The other thing with a vaginal hysterectomy is you can also include certain other procedures on the vagina to help with incontinence or prolapse where things are falling down. You can kind of tighten things up. So the vaginal hysterectomy, number one, you got to be able to pull it off, and number two, it's got to sort of accomplish what you want to accomplish. Abdominal hysterectomies are really done now mostly for cases that we think are going to be really complicated or difficult, because you've got better exposure, you've got your actual hands on things. So if you think there's going to be a lot of scar tissue, or if you have like a really big uterus, that would be a reason to do an abdominal hysterectomy.
Okay.
Most hysterectomies now are being done laparoscopically because the recovery time. And so I think in general, for most people, if you can kind of pull it off, if you're able to accomplish it based on how big the uterus is, how much scar tissue, that kind of thing, then laparoscopic is usually the first choice. So there's a lot of different things that go into the decision. And part of it is skill of the surgeon. We all have, I'm a better vaginal surgeon than I am a laparoscopic surgeon, probably because of my training. So we all have our skill sets. So when I was in Ventura, I had a partner that was a really slick laparoscopic surgeon. So if I had a case I thought was going to be a difficult case, I'd have him do it and I'd assist him. And he'd send me his difficult vaginal cases. So, we all have our skill sets, and it's important that somebody, in any field, but particularly in medicine, to take a good accounting of what you're good at and what you're not as good at, and, try and stay with your strengths.
Right. I agree. We can't be all things to all people. Yes,
right.
I totally agree with
As much
that.
as we want to. And I've had patients mad at me. It's like, but I trust you. I'm like, the reason you trust me is because I'm telling you that I shouldn't be doing this.
Exactly. I know, because I'm honest and I'll always tell you the truth. So this vaginal one is fascinating to me. So tell me real quick before we move on to the next thing, because I know there's so many other topics to talk about, but so is that like the fastest recovery? Why would one do that it that way?
It's not. Laparoscopic is probably a little bit faster than vaginal. They're pretty equivalent. But the nice thing about a vaginal hysterectomy is there's no abdominal incision. So there's no scars. Risks are different, really. You eliminate all the laparoscopic risks. And it's a much faster surgery. So generally, which isn't just good for the surgeon, the general idea is that the longer you're under anesthesia, the more risks and the more the recovery is. It's a little bit hard on the body, So if you can do a surgery in a half an hour versus an hour and a half, you're probably better off doing the half-hour version for everybody involved, but particularly for the patient, because there's less time under anesthesia, there's less time, being operated on. So you end up with less bruising and stuff like that.
Yeah. Okay. That makes sense. And then for post-operative care after a hysterectomy, are there what should we expect in terms of recovery for something like this?
So it really depends on, again, the type. So an abdominal hysterectomy, it's going to be a good 6 weeks before you're kind of doing all your stuff. And even then, it's honestly going to be longer before you're really 100%. Simple vaginal hysterectomy or laparoscopic hysterectomy, probably back to work in a couple of weeks for most people. Sometimes longer, everybody's a little bit different in how they recover. So there's a pretty big difference in recovery time and, for the various surgeries and to some extent, long-term ramifications. So, that's another advantage of a vaginal hysterectomy is you don't get as much scar tissue in the abdomen as you would with, especially an abdominal hysterectomy, but also with a laparoscopic hysterectomy.
Right. Okay. And so what about, maybe we switch gears a little bit and talk about the average age at which women typically will have a hysterectomy done. I think that's a good conversation to have because I feel like I know we talked about this before we started recording about, younger women being offered hysterectomies. So maybe we can talk a little bit about what the average age is typically.
So as most things in medicine, I think the average age has been moving up as people live healthier and longer. And, you know, the age of childbearing has been getting older and older as, number one, technology allows it, but also kind of the way lifestyle in the United States has changed, and sort of our culture, and that women are spending more time early establishing careers, people are getting married later. You know, that marry your high school sweetheart and like my mom and have 4 kids in 6 years, you know, it just doesn't happen very often anymore, which is probably for the better. And so because of that, women are still wanting children. And so hysterectomy pretty much shuts that door. And so I think that's being put off farther and farther. So 40s and 50s is probably the most common age for hysterectomy. Certainly there's a big variation in that. But that's, you know, that's probably the vast majority of the hysterectomies are done in the sort of mid to late 40s, early 50s.
Okay. Yeah, that's what I figured. And then, so yeah, I wanted to talk about this because I touched on this. I have had, I can't even tell you now, countless women come to me over the years talking about how they've been offered hysterectomies. They're in their early to mid 20s, maybe early 30s. They don't have kids yet. But also, you know, there's the whole hormonal component. And, you know, so that's been offered to them as a solution to, you know, whatever, heavy bleeding, recurring ovarian cysts, endometriosis. What are your thoughts on that?
So it's funny. As a surgeon, I try to avoid surgery for myself and my
good.
patients.
I like to hear that. Yes.
So, yeah, my own personal detriment as far as my own self. So, yeah, I had a knee injury from skiing. I was limping around forever, and my MA is like, "Go get your knee fixed." I'm like, "No one's touching me." So,
oh boy,
surgery is a big deal, and
it is.
and I think some people don't understand that. And I think both doctors and patients sometimes are wanting to jump to surgery more quickly than they ought to. So I think surgery for most of the time is sort of a last choice. And I think trying to do non-surgical options is usually best for the patient. And as I said earlier, fortunately, you know, as technology gets better and better, those non-surgical options are getting better and working better. And so we're able to avoid hysterectomies.
Yeah.
On the other hand, there's a frustration that gets involved as well. And sometimes people just throw their hands up because hysterectomy is going to work. It's like, if you're bleeding, hysterectomy will work.
Very
no
true.
doubt about it. Yeah. And so I think there can be a frustration on both sides. The patient gets frustrated. The doctor, we all get, you know, we're human. We get frustrated because we want stuff to work. And when it's not working and the patient's not happy, we get frustrated. And the patients get frustrated. Sometimes everyone just throws their hands up and says, let's do the hysterectomy and be done with it. And it's not always the wrong choice, but I think sometimes that can be done a little bit early. I know, you know, gynecologists got a bad reputation for my time for doing hysterectomies. I had an attending, he was an old guy when I was young. He was joking around, he goes, when I was training, an abnormal period and one other thing, and boom, we took their uterus out, you know.
My goodness.
So fortunately, things have changed a lot since then.
Yeah.
But you know, a little bit of that probably still goes on to some extent. I think hopefully for better reasons than that. But no, that doesn't mean there are times when hysterectomy is the appropriate choice for younger women.
Right. When would that be? Because I mean, obviously I'm speaking to you from the perspective of a women's health coach, nutritionist. So I work on all of the nutrition lifestyle supplement pieces. And I recognize obviously those are only going to go so far in some cases, but I feel like there really, like you said, there really should be this view that surgery is the last resort.
Yeah. So I'll tell you, I had a patient, super nice couple, who wanted to have a baby. She had really bad endometriosis. She was miserable. We did everything we could think of. Really couldn't get her comfortable. She did some infertility, wasn't successful. And then eventually they adopted these 2 really adorable twin girls. And she came to me and she says, I got my kids. I'm miserable. She was like 28, 29. She goes, I want to be a good mother to these twins and I can't. And, you know, there wasn't really anything left to try. And so I did a hysterectomy on her. I felt good about it. She was very happy. that was a really good situation. So I think that was a time when it was, really appropriate.
Right. Yeah. Which makes
So
sense.
there are situations like that. But again, we had sort of exhausted what we could, and she had kind of come to the point where she was ready. And I think someone once told me, another time in training, kind of the opposite side. They said, you shouldn't do a hysterectomy on someone until they're begging you to do the hysterectomy. That's how you have happy patients. And then, then people are, appreciative of the surgery, and they're not having second thoughts. Gee, maybe I shouldn't have done this. So, it's a important conversation, I think. And this concept that's grown, this idea of shared medical decision making, I think is important, where I see my job really as an educator, and explain the various things, and the various ways that we can help. And then the patient has to decide what's the right way for her personally. And I think that kind of conversation is important, particularly with something as big as a hysterectomy.
Yeah. Oh, for sure. I mean, that actually leads me to the next question about when you're considering a hysterectomy, what are some of the important considerations? Because I completely agree with you. I feel like fully informed consent, really understanding the pros and the cons and everything that, will come with making a decision like this. I mean, I agree with you. That appendectomy I had last year was the first time I've been under anesthesia, I think, since I was like a teenager. And I was terrified. I was like, I don't have to go through any more surgeries. This is a really big deal. And so I feel like sometimes in our society, we don't think of surgery as such a big deal, which, is crazy. But yeah, like, can we talk a little bit about what we should be considering before making this decision and any of the potential risks associated with having a hysterectomy?
Sure. Yeah, absolutely. So, I mean, the first thing is it pretty much shuts the door on having a child. I mean, you can get a surrogate, so there are ways to do that. But as far as, growing a child inside of you, that shuts the door.
Right.
So that's a big one, and people need to understand that. I had a patient, she's 49, had her tubes tied, and I did her hysterectomy, and I saw her 6 weeks later, and she's crying because she can't have children. I'm like, you couldn't have children before I did your hysterectomy.
Oh my goodness. Wow.
I felt bad for her, and she laughed, and we laughed, and she cried, and it was like, I know this is ridiculous, but it's this emotion I'm having. And so I think
there's a finality to it, right? I mean, it's a big deal. Yeah.
Yeah. So that's important for people to understand, even if, logically it's obvious. They kind of need to come to grips with that. So that's a big one. The surgery itself has some downtime, and there's going to be some pain, less with the vaginal surgery and the laparoscopic surgery than abdominal surgery, but still, there is pain, and there's no free lunch. So there is a recovery time, and you're going to need to get help with, if you have little kids or, just whatever you're doing, and time off work. So that's really important. Some of us are workaholics, and, I've seen people on their laptops trying to do work from the hospital, recovering from hysterectomy. It's like, that's not the way to go. So that's an important consideration. And then any surgery can cause scar tissue. And so there can be some long-term ramifications, usually not so much, but more surgeries you have, they'll start building up and can cause problems. So, you kind of don't want to have, a zillion different surgeries if you don't absolutely have to. Some people, seem to have every little teeny thing operated on, and, everyone's got to do their thing, but there's a sort of additive effect to this as time goes on. Yeah. And then there can be hormonal changes as well that happen after hysterectomy. And that sometimes takes people by surprise as well. And so depending on—
That's where we come back to the informed consent part, where if you're losing your ovaries,
right,
you're going to lose your hormones. Yeah,
exactly. And then sometimes even leaving the ovaries in, there can be hormonal changes, which is sometimes a surprise to everyone, including the gynecologist, because that's not the way it's taught in medical school and training.
Really?
But my experience is that it definitely can happen, and it happens, I think, more frequently than people expect.
Like as in your ovaries start to sputter and not work as well without that uterus in place, right? I feel like if you're taking away a piece of the system, then the system just doesn't work as well as it would have altogether.
Yeah, and that seems to be the case. The truth is that if you're a purist and you look at the anatomy, the ovaries have their own blood supply.
Right.
And so removing the uterus in theory should not really affect the ovaries, but it seems to.
Yeah.
There is some collateral extra blood supply that comes through the uterus towards the ovaries. And, I don't know, just something about messing with all that stuff sometimes really seems to affect the ovaries. So I think a lot of it is blood supply, but I don't have a hard explanation for exactly why that is. But my experience is it's not uncommon for women, even after we leave ovaries in, to experience some real hormonal changes, not just right away, but I think they tend to go through menopause earlier. I think the data actually bears that out as well.
Yeah. That's what I was going to ask you if there was some research around that, because that I feel like I've seen it somewhere. And then I continue to hear this story that women they were just talking to me online about this the other day, actually having their tubes tied or having their tubes removed and that affecting the ovary function, and then hysterectomy as well, that partial hysterectomy being the same kind of thing.
Yeah, exactly. The tubal one is even more controversial, but I've seen it. Because again, from a pure, anatomic point of view, it really should not. But now, especially that we're doing tubal removals rather than tubal ligation, I think it has a bigger effect on the ovaries. Again, I think it does disrupt some of the blood supply. And I see that fairly commonly, actually, where women have their tubes removed. Because in the old days, we used to just put a little clamp around the tube or just burn a little section of it, and it wasn't really that big a deal. But now there's data that removing the tubes when you do a tubal ligation decreases the risk of ovarian cancer. So most of the time we're actually removing the tubes. That's a much bigger surgery and definitely I think has a bigger impact. And that's, it's new enough. I haven't seen really hard data on this, but it's clearly happening.
Right. I know it's super helpful. And okay, so coming back to what we were talking about the hormonal impact and the piece of this. So like we were saying before, right? So sometimes women have these hysterectomies and they're not really given a lot of information about what's going to happen to their sex hormones, that estrogen, testosterone, progesterone in particular, because obviously that's where that's our ovaries' job. So can we talk a little bit about that? Like what are these long-term effects? Like what's happening when we have these hysterectomies?
So the easiest way to explain it is a hysterectomy that includes a bilateral oophorectomy. So, but
I wouldn't even try to pronounce that. I
love
that you do.
What a layperson would call a complete hysterectomy, but that's what we would call it, a hysterectomy with an oophorectomy. So taking the ovaries out as well as the uterus. Yep. So the ovaries really are where the vast majority of production of estrogen, progesterone, and testosterone for women occur. And so once you take those out, those hormones aren't being produced. And so you've removed the factory, and it doesn't take long to feel those effects. And they can be pretty dramatic. And, when women go through menopause naturally, the ovaries don't just shut off one day. It's this sort of slow, gradual decline where they become less effective at producing hormones and less, and eventually they kind of gradually stop. And for some women, it's actually a gradual enough process that there aren't a whole lot of symptoms. For a lot of women, there are, and they can really suffer through that. When you do what I call when you have a surgical menopause, which is where we remove the ovaries, you're normal hormones one day and no hormones the next, or essentially no hormones the next. And it's be really dramatic for people. And that can be, for a lot of women, the hardest part of recovery from a hysterectomy, even more than the pain of surgery. And so it can cause hot flashes and night sweats and sleep disruption and mood swings, and all of a sudden, weight gain, particularly around the belly. It can change your libido. It can change your energy levels. It can change the way you accumulate muscle mass. It has far-reaching effects. There's estrogen receptors on almost every tissue in the body. And so the amount of effects that sudden removal of estrogen in particular has, it can be really dramatic for people. And the other thing is that they tend to require a lot more hormone replacement than women that sort of go through menopause naturally. And again, it's because it's just shut off. And so you've got to replace all this all at once. And normally when we do hormone replacement therapy, the ovaries are still making hormones. They're just not making them as efficiently as they once were.
Right.
And so we only have to add back a little bit to sort of make up for what the ovaries aren't making. When you have surgical menopause, when the ovaries are removed, and overnight you go from normal hormones to no hormones, the dose that's required can be a lot higher, and sometimes much higher than any of us expect. And so it can take a little while to get that dose right, and titrate the dose up to get those symptoms under control. So that can be very frustrating, and can cause a lot of disruption in quality of life. It's like I said, sometimes that's the hardest part of a hysterectomy.
I believe it. I mean, I've heard the craziest stories about like what those side effects are like. Just going from having your hormones one day to not having them the next day. And so can we talk a little bit about Winona? Because I feel like this is a huge blessing to so many women who are really struggling because they want to have access to hormones, but they don't for various reasons. So let's get into that because I think it's going to be a boon.
Okay. So Winona is, so I'm the chief medical officer of Winona. I'm part of the team that started Winona. And we're an online telehealth company that does nothing but hormone replacement therapy.
It's amazing.
We've grown this. It's been really successful. It's been super exciting. So we launched 2 years ago in April, and we just hit our 23rd state. We're in 67% of the US population we're reaching now. So we're pretty excited.
That's awesome.
So basically, patients come online. We have a huge education area with articles, there's videos. We do I do a live online Q&A twice a month. Again, I see myself as an educator. And then patients on board where there's basically a sort of an adaptive interview where we, like you would in an office, where we would ask you questions. That's done sort of through AI. And it's all designed to make sure this is safe. So the whole thing, number 1, 2, 3, and 4 is safety, 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 safety. So we want to make sure that patients are appropriate candidates, that we're not going to cause any harm. And so once we get through that sort of screening process, we talk about, symptoms, different options, and then we come up with a plan specifically, for what you desire as far as, would you rather have a cream or a patch or a pill? There's lots of ways to deliver hormones, and what your symptoms are, which medical history, and then we recommend a treatment plan. And then we provide that. We have our own pharmacy. We provide that through the mail. So the nice thing is you never have to leave your home. There's a lot of misconceptions about hormone replacement therapy, both in the lay public, but also in the medical side.
Mm-hmm.
And people are afraid of it, sort of inappropriately. Doctors do it wrong because they don't get good training on it. Patients don't understand. And there's a lot of craziness out there, unfortunately. There's also, unfortunately, there's also the people that are out there trying to take advantage of this and offering sort of ridiculous, expensive stuff that doesn't need to be done. I had a patient this morning who was frustrated. She was at some other company that did this huge battery of tests and wanted to charge her over $1,000 a month for her treatment. And I'm like, well, first of all, you don't need tests. So that's like one of the big misconceptions, is that blood tests or any kind of test for HRT really isn't necessary. There's a huge industry. People are making a ton of money doing blood tests, but it's not necessary. So we don't do any testing because it's not the right way to do it. We could make a lot of money if we did, but we don't want to do anything that's not right. And so, just same in my office. There's just no reason to do tests for HRT. So
you base it on symptomology, right? I think that's what you say on the website. It's okay. Yeah.
And that's the standard of care. There was an editorial a couple of years ago in the New England Journal of Medicine. It was basically, stop doing all these tests. What are you thinking? This is done on symptoms. So it's a really nice thing for telehealth because it doesn't really require a physical exam. It doesn't require tests. It requires a conversation. And that's something we can do really easily on telehealth. Mm-hmm. So we're able to do that safely and effectively. Because we don't do all this crazy extra stuff, we're able to keep costs down. As far as the creams, we compound them. We have these amazing pharmacists, and we compound the creams ourselves in our own pharmacy, and so that keeps costs down as well. And so we try to do this as cost effectively, but doing it safely and well. And the nice thing is, it's very convenient for people. I have my wife, when she needed a pap smear, there was a 6-month waiting period for to get in to get her pap smear. It's like, you gotta be crazy. So it's the access to care is difficult right now, and there's a lot of doctors that either don't believe or don't understand. They never got educated on HRT, and I don't do HRT. So even after your long wait, when you go to see the doctor, that may be your answer. So it's a very convenient, safe, nice way to do it.
Yeah. And so what happens when, so someone will get prescribed the whatever hormones that they are prescribed, whichever works for them. And what if the dosage is too high or it's too low? I know that symptoms of too high and too low of some of these hormones are actually kind of the same, which is annoying. So I'm curious about that. Like what happens in a situation like that? Do they come back to you? Are there multiple follow-up visits, things like that?
Yeah, so when I designed this, really I said, what would I do if this patient was in my office? And so what I would do if you were in my office, I'd prescribe you what I thought was the right dose and treatment. I'd see you back in 3 months. It takes about 3 months to really know, are we in the right spot? And then reassess. If everything's great, then see each other every year. If not, adjust the medicines and see how it goes. And so that's what we do with Winona. I have an algorithm I build over about the first 1,000 patients, and it's got pretty good. And I purposely slightly underdose because my philosophy is I'd rather give someone a little bit less medicine than they need and have to go up than give too much and cause side effects. So most of the time I nail it, but when I don't, it's usually they need a little bit extra rather than, oh shoot, I caused you problems, we need to back down. And that's happened from time to time. So then we do a reassessment just before the 3-month period, and then see if a dose needs to be changed. But we're also available 24/7. I mean, we're not sitting at the computer 24, but we're available for questions or if there's concerns. And sometimes we need to make adjustments before the 3-month. And then sometimes things are working great, and then 9 months in or a year and a half or whatever, the body changes and we need to adjust the dose again, and that happens too. So we're available to do that.
Right. And so, and I should clarify for everybody, this is if you've had a hysterectomy or not had a hysterectomy. I mean, this is pretty much for everyone across the board, I assume, but mostly for those in perimenopause, menopause, right? I imagine you're not really just giving out hormones to everybody in their 20s.
No.
Yeah.
So yeah, the current guidelines are that you shouldn't start HRT for the first time in women after 60. So we don't accept patients that are older than 60. If you're already on HRT, you can continue after 60, but it's risky to start. So we sort of draw the line at 60. We open at 35, and the reason for that number is that it's interesting. It's a lot younger than you would think, but about 15%, about 1 out of 6 women completes menopause by 45, and symptoms tend to start 7 to 10 years before that. So we sort of start at 35. There are people that go into menopause before that. So there are, few individuals that can go through menopause at 25 or 30. But that really requires more of an evaluation because something's unusual. And so there may be other things going on. So I don't really feel comfortable treating people below 35 because I think they need more than what we can offer.
Right. Yeah, again, that's like a premature ovarian.
Premature ovarian
type
failure,
situation.
yeah.
Right. Yeah,
So,
exactly.
and that requires more of an evaluation. So we sort of start at 35 to 59 and 364 days, to 60, and that's sort of the age range that we take care of, and that's the brunt of when people would need hormone replacement therapy. Most of our patients are, mid 40s to mid 50s.
Right. That's super helpful. This is amazing. And I feel like these kinds of services are going to just be so tremendously helpful to so many women, because I feel like I get at least a message a day from someone asking me about where they can find someone to help them with this specific issue. Because like you said, there is there are definitely misconceptions in more conventional medicine and with more conventional medical doctors around hormone replacement therapy. And then there's a lot of confusion around traditional versus bioidentical and using a compounded pharmacy and all of these kinds of things. So I feel like it's very overwhelming to the layperson, and they just don't know where to go.
Yeah, that is a big problem. And honestly, the medical field isn't helping any because there's a lot of misconceptions in the medical field as well. There was a big study that came out in 2002 called the Women's Health Initiative Study, which sort of turned everything upside down.
Yeah.
And unfortunately, it made the newspaper headlines before people could really read the study, and it scared everyone to death, patients and doctors alike. And so that's been a problem ever since, because for 10, 15 years in training programs, people weren't trained how to do HRT because it was like, look, you're never going to do this. And, so don't waste your time learning about it. And it turns out that that study was helpful, but it didn't really say what the headline said it said. And it was basically, look, you got to treat this right, and you got to be careful and prescribe it to the right patients. But now we know that, when patients are selected appropriately and they start HRT before 60, they actually have a higher life expectancy if they're on hormone replacement therapy, and a higher quality of life than if they never had hormone replacement therapy at all. So for a lot of women, it's a really good thing. But there's this big disconnect between, the education and what people understand about it and what the data actually says. So it can be frustrating for everyone. Yeah.
Yeah, I bet. I'm sure it has led to many hurdles. I know, and it does make me think about that generation of women in the early 2000s who probably really would have benefited from this. And so there were multiple decades of women who just never got any. I feel like I know a number of women in my life who never went on hormone replacement therapy. And there are a lot of health issues that they have that I think could definitely have been mitigated by having replacement, but here we are. So now we know.
Watching that pendulum swing, has through my career has been really interesting. But fortunately, I think we're in a much healthier place in what we understand about hormone replacement therapy. We're doing it because of that study. We're doing it safer and better than we would have without it, and we're just finally starting to recover from the misconceptions about that study. Totally. But for most women, it's safe and effective and makes a big difference. For sure. So it's a matter of finding someone that is educated enough to do it well, and do it right. And that's the important thing.
Yes. Well, I thank you for all of this. This is really, really helpful information. Can you share where everyone can find Winona's services?
So bywinona.com is our website, and you'll go on there and you can take a quiz to see if, this might be the right thing for you. As I said, we have a ton of blog articles, a bunch of articles that we wrote that are all referenced with scientific studies, videos, and other things. And you can also onboard there. So it's bywinona.com, and you can start the process there.
Amazing. Thank you so much, Mike. This was really, really great information. I so appreciate your time.
Oh, my pleasure. Thank you for having me.
That's a wrap. Be sure to click that subscribe button to join me for more Girl Talk Gone Menstrual in upcoming episodes. But in the meantime, check out my latest Period Party episode. And if you're looking for a deeper dive into your hormones, go ahead and take my period quiz at NicoleJardim.com/quiz.